Hello and good evening, everyone. Welcome to the 125th session of Mero Eye's Eye Talks webinar powered by Mero Eye Academy. This is Miss Olu Gautam signing in as your host for this session, and I'm so glad to have you all this evening. Prior to the beginning of today's session, let me tell you all that we will be having our discussion session at the end of the webinar. So I request you all to drop your queries in between the session to our live chat box. So we shall discuss it later on our discussion session. So without any delay, I would like to move ahead to inaugurate today's session. And as a speaker, we have Dr. Addepalli Uday Kumar, who will be talking on topic role of optometrists in glaucoma detection and management in different eye care settings. So before that, I would like to give a short introduction. Dr. Uday is an optometrist at Specsavers, South Australia. Also, he is the registered optometrist of Australia as well as New Zealand. So I welcome you, Dr. Uday, to our platform on the behalf of Mero Eye Foundation and all our participants. Over to you, Doctor.
Thank you, Solu. So let me share the screen. So is the presentation visible?
Yes, Doctor, it is.
All right. So a very good afternoon, good evening, good morning for people joining from all over the world. So, so as you all are aware of the topic of the discussion today, I'll be talking more on the role of optometrists in glaucoma detection, a generalized perspective, which means that role of optometrists in different geographical communities. So the outline of the presentation gives we'll be going through the definition and burden of the disease, and then risk factors involved, and the skills required and challenges faced to diagnose the condition, and also your scope as an optometrist. So starting with the definition and burden of the disease. I'll not be going through real details, going into the details of glaucoma definitions and all, because I'm sure by now you might have attended so many sessions on glaucoma disease definitions and all. So anyways, glaucoma is a group of eye diseases characterized by progressive optic neuropathy, which with visual field loss. And the prevalence of glaucoma, obviously, it is well aware that it ranges from region to region. And the global glaucoma prevalence is about 3.54%, wherein the primary open angle glaucoma is 4.2%, and primary angle closure glaucoma accounts for 1.09%. So in this rate, it is projected to be about 112 million people with glaucoma worldwide be affected by 2040. So it disproportionately affecting people in regions in Africa and Asian region. So the major risk factors include age, which most of us know, genetics, ethnicity, as I have previously mentioned, African and Asian descendants, and high refractive errors. Usually, primary open angle glaucoma is associated with high myopia, and angle closure glaucoma is associated with hyperopia. And intraocular pressure, which is the only modifiable risk factor as of now. And the central corneal thickness, which is very, very important, and it has been neglected for many years. But good that most of the practices are paying attention to central corneal thickness these days. Large optic discs, blood flow dynamics, and various other risk factors. So when it comes to the diagnosis, at the primary level, the most important things that we require for diagnosis is the visual acuity, intraocular pressure, family history, and clinical signs, which include signs on pupil like sphincter atrophy, sectoral sphincter atrophy, etc., and anterior chamber depth, whether deep or shallow, disc hemorrhages, optic nerve head appearance, retinal nerve fiber layer defects or thinning, and visual field. If not visual fields, try to do at least confrontation. In best case scenario, which means by saying that, I mean that in best settings where resource, with all the resources available, then the best case scenario would be having an OCT, standard automated perimetry, fundus camera, and pachymetry. So in resource poor setting, then the basic things that we require to detect glaucoma is slit lamp, for slit lamp proper slit lamp examination, tonometry, and 90D, and above all, clinical skills. Clinical skills is the most important thing, because having a hack street slit lamp or a Zeiss top class slit lamp and all the equipment, not having proper clinical skills, it's not going to make any sense. So what are the skills required and the challenges that we have to overcome? So the skills required includes history taking, clinical examination, most importantly slit lamp techniques, and intraocular pressure recording, gonioscopy, fundus examination with for proper optic disc assessment, and preferably grading the disc according to the most opted disc damage likelihood scale, and findings of disc, which is very important, which also include disc hemorrhages, notch, or thinning of the neuroretinal rim, etc. In this slide, this shows the continuum, or it is also called as the glaucoma continuum, wherein glaucoma presents from undetectable phase to asymptomatic and then to functional impairment. So a normal patient, as the acceleration of apoptosis increases, ganglion cell death or axon loss will take place, which finally results in retinal nerve fiber layer defect and then to functional impairment. That means the visual field damage is seen in the the field damage occurs. So in this, until recent times, it was no glaucoma was only detected after the visual field damage has occurred, means at the functional impairment stage. But now, because of the techniques that we have got, because of the examination skills that we have got, we can diagnose a condition or detect a condition at an asymptomatic disease stage, which means that at a stage where the patient already has a retinal nerve fiber layer damage, but still visual fields being normal. That's called as pre-perimetric stage. So it all depends on the clinical skills. So the challenges include training and experience, which is the most important thing. This is from a publication, of course, a publication of my own, wherein we have mentioned that if trained in optic disc assessment and gonioscopy, an optometrist can appropriately diagnose glaucoma using gonioscopy and disc assessment as indicators. That is useful in situations where glaucoma specialist ophthalmologists are unavailable for whatever reason. We propose, therefore, it would be reasonable to use optometrists to facilitate the screening and diagnosis of glaucoma, provided that they have been suitably trained and have access to appropriate equipment. This is from this publication, wherein we have assessed the agreement of glaucoma specialists and experienced optometrists in gonioscopy and optic disc evaluation. So the training and experience part, the challenges involved. Individual motivation is the most important thing, wherein to expand the skill sets, because until even though we might have a very good world-class teacher who can teach you with all the important skills, if the optometrist doesn't have that motivation to learn, there's no point. And to improve skill sets, to avoid false positives. Obviously, when you improve your skill sets, you will not, you will not overburden the glaucoma clinic with normal physiological appearance of the disc as disc suspects or glaucomatous discs. So develop your own referral pathway to ophthalmologists or optometrists for an opinion helps improving your relationship with the team members. So this is in case, irrespective of what kind of practice that you are in. Like suppose yours is an individual optometry practice, then try to build up a relation with the nearest ophthalmologist, saying that all these glaucoma suspects that you have, you'll be referring to them, so that you can also learn. There would be a mutual learning, and your professional relations also would improve. As I said, the type of practice should not be a restriction, and also not to. I advise each and every optometrist, do not restrict to refraction. So I know in most of the optometry practices, we just do refraction and give a pair of glasses. But along with that, make it take it as an opportunity to do a comprehensive examination of every patient who attends you, and also encourage the same thing. So the scope of optometrists, this is again from one of my another publication, which says that the optometrists provide a reasonable alternative for primary screening with no loss of detection ability. That's an important statement. And expansion of this option by increasing collaboration between ophthalmologists and optometrists can bring benefits in terms of lowering the impact of glaucoma on the community as a whole by increasing early detection and instigation of effective treatment. So in patient history, these are the various skills that you require in each of those categories, or the challenges, or the reason, or the areas where you need to, you have a scope to develop. In the patient history, where we need to pay attention to ocular history, for example, all those which down the line lead to glaucoma, blunt ocular trauma, hyphema, anterior segment trauma with angle recession, etc. Medical history with high-risk medications, diabetes, peripheral vasospasm, all those conditions that can have a direct or indirect impact on the blood circulation of the eye, and that may lead to changes in the optic nerve head and the visual functional vision. Risk factors like age, which we have already discussed. Family history, as this is again another important one. And as we know, the incidence in first degree relatives is 3 to 5 times that of general population. Race, as we have already discussed, African descendant population most at risk, Asian descendant for angle closure glaucoma specifically. Slit lamp examination. In slit lamp examination, we should be able to identify narrow angles by doing a proper Farnharic test or a shadow test, and pseudo exfoliation. When the pseudo exfoliation on the lens capsule or pupil margin, usually pseudo exfoliation is missed because early forms of pseudo exfoliation we see it is seen only on dilation or under dim light. When the pupil dilates, it is usually seen on the anterior lens capsule on the lens. So it is missed. So that careful examination is important for pseudo exfoliation. Pigment dispersion, wherein we see iris trans illumination defects and pigment deposits on endothelium as well. And in these cases, we also see some hyperpigmentation of the posterior trabecular pigmented trabecular meshwork on gonioscopy. And also the configuration of the iris would be a bit concave. And other signs of secondary glaucoma, which include rubeosis or atrophy or any uveitis related changes. Disc assessment. Enlarged cup disc ratio with the consideration of disc size and insertion, and cup to disc ratio asymmetry, usually an asymmetry of 0.2:1 between the eyes. Neuroretinal rim, look for thinning, focal narrowing or notching of the neuroretinal rim, typically in the superior and inferior poles of the optic nerve head. Meaning to say that to look for the ISNT role. Optic disc hemorrhage, which is also called as transhemorrhage, which is in the layer, nerve fiber layer level. Blood vessels at optic disc, barring or bionating at the optic disc. That's called also, we term it as contour cupping. Rather than color cupping, contour cupping is very important, wherein we try to see the way the vessel is bionating. Retinal nerve fiber layer, to look for retinal nerve fiber layer defect in this, usually in the superior and inferior arcuate bundles. And also this peripapillary atrophy, zone alpha. PPA represents loss of retinal pigment epithelium and choriocapillaries, leaving intact choroidal vasculature. And the assessment and equipment required. So for intraocular pressure, we need the gold standards, which is the Goldman applanation or an eye care or a tonopin. These are the reliable equipment that are required. Most of the practices use non-contact or air puff tonometers, which are known to give falsely high readings. So do not depend on those readings to say and diagnose any case as glaucoma just based on those non-contact tonometer readings. So in central corneal thickness by pachymeter, or you can also use an anterior OCT, anterior chamber angle using slit lamp or gonioscopy, optic nerve head using slit lamp and a fundus lens, usually 90D or a superfield view or a 78D, depending on whatever is available for you. Retinal nerve fiber layer assessment based with the same slit lamp and fundus lens. The threshold visual fields, using the automated threshold perimetry using 24-2, and if the central vision is involved, then go ahead further, do a 10-2 or a 30-2, tailored to the patient and degree of visual field loss involved. The diagnostic equipment that is required involves optical coherence tomography, obviously posterior OCT, which gives information on the ganglion cell layer, neuroretinal rim, and also the retinal nerve fiber layer, which is also called as GCC. Um, uh, yeah. So the the OCT or anterior OCT, that is to see the anterior segment assessment, including anterior chamber and corneal thickness. Anterior segment OCT is preferable for CCT, but most of the angle assessment, I would always prefer gonioscopy rather than anterior OCT for angle assessments. And scanning lasers like HRT, GDX, and in most of the places, these machines are not used now, because the posterior segment or the spectral domain OCT that is available gives almost most of the information that we get from HRT or GDX. Let's discuss some interesting cases, which will and in these cases we will learn how important clinical assessments are, and the advantage of having other equipments in any practice. So this is a question to all. Is this the fields of a normal patient or a glaucomatous patient? Okay, you can just answer to yourself. So obviously, by looking at the grayscale, I know for visual field assessment, it is not a good idea to look at the grayscale. But if you see the pattern deviation, not significant points which are depressed, and it looks really good. And GHT saying within normal limits, there's not much of a mean deviation loss there. So practically speaking, it is a normal, it should be a normal patient's visual field. So this is the disc of the same patient, which involves, if you see the neuroretinal rim, so it is definitely, it's a large disc. The size appear to be larger than what we usually see. And if you see the cupping, also it is large, so it looks more of a physiological. But if you see the neuroretinal rim, which is very narrow, but very healthy, pink, all throughout, except in the inferior region. In this inferior temporal to inferior region, the color started changing in the inferior at 6 o'clock position. And between 4 to 5, you see that there is no neuroretinal rim at all. So that it could be a, a notch, localized notch there. And for the same patient, if we do an OCT, this is what we see. Okay, so this RNFL thickness map, this is exactly same information that we get in GDX as well, wherein the normal thickness pattern should have in the upper 120 degrees and then the lower 120 degrees. It should be in yellow to red region, but we see that the whole thing is almost in blue, which means that the thickness is, you can compare with the thickness of red RNFL scale on the left here. And if you see this particular region where we have discussed earlier, where we thought that there is a notch, it indicates that a wedge-shaped retinal nerve fiber layer loss, indicating very clear-cut wedge-shaped thinning of the nerve fiber layer, and correlating change in the thickness, quadrant-wise thickness as well in the inferior and temporal. And if you see the RNFL deviation map, it shows in the same region, we see that there are a lot of pixels that are depressed significantly, which is of up to P less than 1%. This is another case wherein we start from the other end, where by comparing the spectral domain OCT report. It shows a very beautiful green color, which means that this is what we expect to see whenever we see a OCT printout. We want all the thickness to be in normal regions, so that we have all the 4 quadrants to be in green, and all the macular area, ganglion cell thickness, everything in green, both the right and left eye following RNFL thickness, following the double hump pattern and falling in the green region. So the classification also says right eye within normal limits, left eye within normal limits. So obviously this has to be for a normal patient, but let's see what other information says. So that's the optic disc photograph of the left eye. So what do we see here? In the same region, if you see a wedge-shaped dark region. So this is how we examine, we look for nerve fiber layer defect, wherein if you see the whole of this retina is all of same brightness, except this region where the nerve fibers, along the path of the nerve fibers, you see that dark thing approaching the disc. So if this doesn't approach the disc, then it could be physiological, or it may not signify anything. But if there is this kind of nerve fiber layer thinning or the defect, which reaches the disc, that means something is wrong there. And the way forward. So the long-term vision of the present model is for early detection of sight-threatening disease at a community level, and appropriate referral by the optometrist to the specialist ophthalmologist, who can then focus on functional vision assessment and medical or surgical management for the benefit of the individual. So ultimately, this is what we want, right? So in the based on those the clinical examples that we have discussed in a few slides. So based on that, it is very clear that how good our clinical skills has to be. You know, your observation skills, your ability to read each of those printouts, visual fields, or OCT, doesn't matter what all you have. So let's assume a scenario where you don't have OCT or visual fields. Just based on your clinical skills, you know, you can still suspect those two patients as glaucoma because your clinical skills are good. You're able to detect the changes on the disc. You're able to detect the changes in the nerve fiber layer. That's it. There you go. You have every right to refer that patient to a center where you have all these options, or an ophthalmologist who can confirm your findings and get back to you. So that gives you a very good learning exposure. And this is what we have published. And this is again, this paper gives the prevalence of primary glaucoma as diagnosed by study optometrists of LV Prasada Institute. LVPI gleams is the study that we have done, and for which I was the principal investigator. And this is the first paper in literature wherein the optometrist had uh, reported the prevalence of primary glaucomas. This is the first paper in the literature. And the design, I would suggest every optometrist who is involved in public health or in community care, I would suggest everyone to design a model for your own community. And it has to be a shared eye care model. When it comes to glaucoma detection, there is no doubt that it has to be a shared eye care model, because you cannot work with only a vision technician who is, or a refractionist, or you cannot work alone as an optometrist without the support of ophthalmologist, because you just can't say a patient that you have glaucoma and leave it. You need him to treat. You don't want the patient to go blind. So you need the support of ophthalmologist who can treat the patient medically or surgically. So in some parts of the world, yes, optometrists can start the medical management, but in our country, like in Nepal or in India, it is difficult. So we need to have develop a shared eye care model, wherein you want in the ground level, in the community level, where where the optometrist cannot go to door houses and get the patients for screening. So we need people who are working in the community to work along with the optometrists, and the optometrists with proper clinical examinations can detect early changes, early clinical changes in relation to glaucoma or any other disease for that matter, and then refer to the specialist ophthalmologist for further care. So that's exactly this LVPI Gleams model is actually a shared eye care model that we have used for glaucoma detection in the community. And this is the project report again. This is published in the site annual Your Own journal. I'm happy to present this in your iTalks session. That in this is a project led by an optometrist, like that was me, and it has got a potential to work in any kind of geographic region, depending on the jurisdiction. You just need to make minor changes, but definitely you can use the same model, wherein optometrist plays a very important role in glaucoma detection. And in this particular paper, I have discussed the accuracy of vision technicians. A vision technician is a person who is trained in basic slit lamp examination and refraction. And if those vision technicians are trained with some skills required for glaucoma detection, how are they going to perform in the community level? That's what the study talks about. And we have done a study wherein without that training on, particularly on glaucoma, just after a normal vision technician, how would they perform in glaucoma detection? Then it was published, and the sensitivity was just about 25 or 26%, so which is not that great. And then in this particular paper, we have discussed how that if for the same vision technicians, if we train some of glaucoma detection skills, how are they going to perform in glaucoma detection? And the results are really surprising. So I know this is a very busy slide, but I will try to simplify this. So when it comes to the diagnostic accuracy of each of those VTs, VTs is vision technicians. So you can follow the legends at the bottom of the table. So based on their ability in detecting glaucoma clinically in the sense to by using visual acuity, refraction, slit lamp examination, intraocular pressure, and direct ophthalmoscopy for fundus examination or a 9TD. So just based on that, their ability has from 25, 26%, which is without glaucoma training, it has now improved to 59%, which is a significant improvement. And if you see based on only non-mydriatic fundus camera, they don't have any other information. They just have a non-mydriatic fundus camera, and based on that, it is 34%. And if they have only frequency doubling technology, or we call it as an FDT matrix, only based on that, it is just 11%. That is because it gives various other conditions that can are generalized conditions that can affect FDT results. And now moving on to the combination of these clinical examination with FDT, that has improved the sensitivity to 96%. However, the specificity has reduced to 74%. And that is because of FDT, because FDT usually it gives generalized results. It can be cataract as well. And when it comes to FDT and non-mydriatic fundus camera, because there is no clinical examination, so that is just 35%. But with clinical examination and a good non-mydriatic fundus camera, then the percentage, the sensitivity is 83%, which is really good. Okay, so that's the impact for a 1-year trained vision technician. So if that's what they can do, imagine what an optometrist can do. So it has to be close to 99 to 100%, right? So that should be the level of clinical skills that I want each of the optometrists to have. So now let me discuss the Specsavers model, which I'm really so uh, I really like this model because all these years I only used to dream that every patient should have an OCT along with proper clinical skills, because only that will give us a 360 degrees coverage for that particular patient who attends an optometrist for an eye examination. So let's see what this model, Specsavers model, has done. So OCT, we started OCT for every patient, which has improved the lead time in glaucoma detection by up to 8 years on visual fields. If you have to diagnose someone to have glaucoma based on visual fields, it takes 8 years. Whereas with OCT, you can just do it immediately if there is any suspicion. And the false positive rate of glaucoma referrals to ophthalmologists has decreased to about 17% from over 20%. Okay, so that's what I said in one of my previous slides. when your clinical skills have to be polished, because you don't want the false positives, because you don't want to burden your clinic with false positives, because that's a waste of time as well. And reduce the level of undiagnosed glaucoma among our patients. Our patients, in the sense, in this region of Australia and New Zealand, patients by at least 60%, which is a major, significant percentage. And 75% of open angle glaucoma cases are uncomplicated, and that can be managed by the optometrists alone. And when I say managed by optometrists, optometrists need to be, update their skills if they want to manage or co-manage a glaucoma case along with an ophthalmologist. So the take-home message is to improve your clinical skills, get trained or get endorsed for glaucoma therapeutics, or that is, in regions wherever it is applicable for, and keep yourselves professionally upgraded. Always, there is no ending for learning. So always try to, keep on digging into the clinical skills, how best you can improve. And comprehensive eye examination, which has to be opportunistic, as I told in one of the slides again. Whenever a patient comes for a pair of glasses, take it as an opportunity to do the 360, to provide the 360 degrees care, so that you don't miss any sort of glaucoma, or not only glaucoma for that matter, any kind of, when you look at the fundus, you will be able to pick up various other findings along with glaucoma alone. And shared eye care practice, this is again and again is my focus, and I always encourage everyone to practice shared eye care models, and always try to build that rapport with other professional colleagues, and influence the health system with the quality of your work. Okay, only the quality involved in your work will be able to influence the health system. You should always remember this. Okay, only if your quality of work is great, then any kind of change from the Ministry of Health is possible, because your quality speaks. And focus on the rural or socially disadvantaged populations. Never ignore this part of the population in any community. Okay, so this is one of the motivation wherein, if you see me, I'm currently working in Australia. When I say Australia, most of the people ask me, where in Australia are you heading to? Sydney, Melbourne, Brisbane, or any of these major cities? But no, I'm working in a place which is about 240 kilometers from Adelaide. Adelaide is a reasonably busy city, and it is a regional area which is called Berry. Okay, so it is because of that motivation I prefer working in rural or regional areas, because this is the area where you need proper care, because in cities there are so many others to provide of all these care that is required, but the regional areas are the populations that require the best quality care, because there's hardly not many people who will be willing to go and work there. So these are the references that I have used for my slides. And this brings to an end of my presentation. Thank you so much for your attention, and good luck with your learning. And I'm open for questions now.
So you are right.
Okay. So thank you so much, Dr. Uday, for such a wonderful session, and I hope your words will inspire our audience for the detection and management of glaucoma in various settings. So with this, we are to move towards our discussion session. So are you ready to take our questions?
Yes.
So we have our first question from Mr. Manish, and he have asked, can ocular ischemic syndrome can cause glaucoma?
Ocular ischemic syndrome itself will present in various, along with various other findings. So all these blood related or blood flow dynamics can cause changes that are similar to glaucoma that with your clinical skills, you should be able to rule out or separate the causes. And, that identification is what is important. When you have diagnosed a case as ocular ischemic syndrome, then you will be able to treat the cause for ocular ischemic syndrome. Whereas if you misdiagnose this particular case as glaucoma and you keep treating glaucoma, you will miss the cause for ocular ischemic syndrome. Okay, so you need to be able to, ocular ischemic syndrome, usually pressures will be low, and that might present with some anterior chamber inflammation. So sometimes this inflammation can lead to secondary glaucomatous changes. It can.
Okay, I hope we got his answer. For moving forward, we have our next question. So what would you suggest to the optometrist would do first if angle closer glaucoma comes in the clinic? So I guess the questions were addressed as, what would you suggest to the optometrist if patients come with angle closer glaucoma in their clinic?
So it depends on the stage of the angle closure glaucoma. Is it an acute stage or it's a chronic stage? If it is acute, then obviously depending on the area or the geographic region and the jurisdiction involved there, you will be able to use some medications or no. And most of the areas in general, I would say, you're not allowed to give any medications for acute conditions. So you will have to immediately contact the ophthalmologist and make sure that this patient is seen immediately within hours.
So I can see another question. So what is the best way to diagnose glaucoma if we don't have any ophthalmic instruments?
Check vision, check for pupil reactions, do confrontation if it is advanced. But obviously for early stage glaucoma, wherein if you remember the glaucoma continuum slide, in that I told that your aim should be in detecting glaucoma at an asymptomatic stage. So when you want to detect an asymptomatic stage glaucoma, obviously all these equipments are a must. Without slit lamp, you cannot assess proper anterior chamber, or without a fundus lens, you cannot get to see the nerve. So at least in the worst case, you should at least have a direct ophthalmoscope to look at the disc. So the basic instruments are a must.
So I hope that answers the question. So I can see the next question. Designing a model for glaucoma detection based on one's community needs is a great device. Adhering this approach will be beneficial in early glaucoma diagnosis and management with substantial success. So I guess this is just a comment. So
thank you, Sunila. Yes.
So yeah, so we have already answered this question. So next question, please. So I guess these are only the questions that we have got from our attendees till now. So we will be waiting for some few more minutes if we get the
yeah, sure. I don't mind. I'll wait.
Yeah. And before that, I would like to do a short announcement that we have started our program for the telemedicine. So I request you all to know about it more by visiting our website www.meroeye.com, and also we'll be having our myopia symposium on 3rd of July delivered by Brain Holden Vision Institute. So I welcome you all for the symposium, and I request you all to register it as soon as possible. So also I invite you all for the next session of iTalks on the 30th of July, that is to be delivered by Dr. Anita Arvind on specialty contact lens. Thank you all. So let me check out if we have any more questions. So yeah. So I have one question from Inner Vision. Inner Vision have asked that I want to know if there is any treatment for the visual field loss followed by glaucoma.
No, unfortunately, we cannot get back bring back the vision that is lost. We can only aim to stop the progression.
So again, I have another question from Mr. Vishnu. He have asked which treatment is best for the glaucoma.
It depends on the type of glaucoma. When it comes to angle closure glaucoma, the best first line of management starts from doing a AUK peripheral iridotomy and then medical management if required. Otherwise, for primary open angle glaucoma, it starts with medical management. And if that doesn't work, then surgical management. In both the cases, if medical management fails, then surgical management. Depending on the regions, like the many first world countries where in primary open angle glaucoma, they first would consider selective laser trabeculoplasty before the medical management. Are you there?
So I hope that answers the questions, and I guess Mr. Vishnu have received his answer already. So these were only the questions that have been raised by our attendees till now. And considering the time limits, here I announce the closure of the discussion session. And I would like to thank you all for coming up with your queries and making the session more interactive. So further, if you have any queries, you can directly write us to us. We will forward it to our speaker, Dr. Uday, and he will forward anytime his leisure time with his answers. So also, I would like to take my moment to thank our speaker, Dr. Uday, for his time and his valuable insights. So we are to the end of today's webinar, and before we wrap up, I request our speaker, Dr. Uday, to share his few words of honor to our platform.
Sorry, I didn't get.
Doctor, please share a few words to our platform before we wrap up the session.
Okay, so first of all, let me congratulate the whole team, Mero Eye team, because you're really doing an amazing job towards the development of the profession, and not only making efforts, but I see those efforts in bringing that quality education to people who are willing to learn. That's an amazing part of your what you all are doing. That's really amazing, and I just wish you all the best, and keep continuing your activities towards taking the profession to the next level.
Thank you so much, Doctor.
It is not just doing making some effort, but making sure that there is quality involved in that is what is it's difficult. And when you can maintain that quality, as in one of my slides I said your quality will speak. So when you maintain those quality standards, obviously you'll be reaching those heights.
Thank you so much, Doctor. We hope to continue our work even in the days to come and foster the optometry education, not only nationally, but globally. So thank you so much for your time, consideration, and your valuable insights. Thank you so much.
Thank you so much, Salu, and thanks to Kapil and team. Keep up the good work.
Thank you, Doctor. With this, I want to end the today's session, hoping to see you on the next one. Stay safe, stay connected. Thank you, everyone. Thank you, Doctor.